Good afternoon and good evening, everyone. I just had a talk with Dr. Indranil Mukhopadhyay. He's having some trouble in joining in through his laptop, so that's why this is delayed. But we will resume shortly, and we are exploring the alternatives for this one. Thank you. Hi, Dr. Indranil. You
Hi,
connected over
hi,
the phone?
Chandrakant. Really sorry, somehow my laptop it's not getting connected. Give me few seconds. I'll just start the. I'm just getting my headphone connected with.
And then you can share your, Indranil, you can share your slides with us, and then someone from our end will project.
Yes, I have already done that. I have sent it to Namrata. I think she would take. She would put it up.
Okay.
In the world of apps always surprise you. I had kept everything ready and prepared, and I was thinking that it will like I wanted to join a couple of minutes before time, but that also didn't happen. Just give me a few seconds. Now the stand of my headphone to give me a bit of joy. I'm just also.
So I have not received your mail. I think it's not there on my mail. I think you have shared with.
uh,
Yeah, I guess.
I shared with Navya. Sorry. Oh, I got an email from Navya, so I forwarded her. Can you tell me your email ID?
Sir, I'll just send a hello to you. Just.
You can just, I'll forward you. You just tell me the ID. That is easier. Yeah.
Okay, sir. Okay, sir. It's NA
NA?
NAMMU 7755
Yes. 7755.
@gmail.com.
Yes. Ideally, we should have. Have you received it?
I'm just checking, sir.
Okay. So in the meantime, when this is
Let
received,
us start. Yeah.
let us start. And let me start by welcoming Dr. Indranil Mukhopadhyay. He is one of the known expert in area of health financing, health economics. He currently works as associate professor, right?
Professor by now.
Okay, professor by now. So professor at JP Jindal University. He's widely known and extensively involved in health financing and universal health coverage related work in India, including policy work and advocacy work. Dr. Mukhopadhyay has been extensively involved in the development and drafting of India's national health accounts, the universal health care or universal health coverage discourse across the country. So when we were planning this FPHS Dialogue 2023 with 3 speaker series, Dr. Indranil Mukhopadhyay was a natural choice. So Indranil, I have already spoken some of the things about FPHS Dialogue, so I will not repeat those aspects, but key that we curated these 3 topics which are complementary to each other. This is 1 hour session. We have already completed 2 talks on broader principles of health financing, then out-of-pocket expenditure and catastrophic expenditure. And this third talk intends to focus upon health insurance and universal health coverage, or health financing and universal health coverage. Uh, our participants for this talk are like some of the fellows which you see on the screen are Public Health Research Fellow of Foundation for People-centric Health System fellowship program. The cohort include medical doctors, but also public health experts, or those who are pursuing their masters of public health. We have fellows from India, but also from fellows from other countries who are part of our international fellowship program. In addition, this program is being live telecast on YouTube as well, and then it will be stored there so people can watch. And this will complete the 3-part series. So this your talk is third talk in this dialogue series. But that doesn't mean that we cannot have this dialogue in future. Like we are in fact planning that there could be a bonus talk where all 3 speakers who are delivering individual talk will be invited, and then we might have a more of a question answer format. Without any further delay, I first hand over to Namrata to check whether she received PowerPoint slides or if she has some additional suggestions.
Okay, so a very good evening to our respected speaker and of course our moderator and our third national cohort of 2023 and first international cohort of 2023. So as we know, August month is a very important and very special to us because this is also our annual month of FPHS, and I'm glad that we are having this series. So this is our third series, which is very knowledgeable and very valuable. And I want to thank Indranil sir for your valuable time. And I'm extremely sorry from delay by my side. A small announcement for our fellows, because in between the Zoom meeting, in between our webinar, I'll share attendance form. So I request all the fellows to please mark your presence. And if you have any question, please just comment, or you can raise your hand, because at the end of the webinar, we all will get the chance to ask questions. Even I can ask the questions, no problem. I think so. Am I allowed to ask questions, sir? Or is
Yes,
just
absolutely.
Yes,
Thank
of
you.
course.
Thank you, sir. So, okay, fine. So we are also live streaming on YouTube, and we'll be getting questions from YouTube also in the comment section. And okay, so am I supposed to share my screen, sir? Should I share my screen? Okay,
That would be
thanks.
Yes, with that, over to you, Indranil.
okay. Okay. Thanks, Chandrakant, and thanks, Foundation for People-centric Health Systems, FPHS. It's the kind of fellowship and related work you are doing is quite commendable and much needed in a national and international context also. And it's thanks for giving me this opportunity, and also my task is uh, made sure made easy by some of the more prominent and very illustrious presenters, Shankar and Rupali. They have presented some of the key issues and foundations, and it makes my task easy. At the same time, also difficult, because it's always very difficult to follow such eloquent scholars like my predecessors. What I'm going to do today in a short period, and I'd like to start by apologizing because of those technical difficulties. Zoom was not opening, decided not to open on my laptop right now. I had 3 meetings in the day earlier on Zoom and it worked, and I thought this will work. But the world of apps always love to surprise us, and this time it did to me. But apologies for that. What I'm going to do here today is that I'm going to talk about, following from the conversation that Shankar had and Rupali had, is to talk about the core essence of universal health coverage. I'm sure, which you all have some idea, and then link it with the kind of financing we need for universal health coverage, and then go into more comparing India and other countries in terms of where they stand, how they're doing in terms of universal health coverage, and then look at some of the critical policy level issues that are relevant for India. I know this fellowship also involves other countries, and some of this would be, I'm sure, helpful and relevant for other contexts. So can we go to the next slide, please? And so some of this, I'm sure you have already been used. Can you move the slide to the next, please?
Yes, sir. Yes, sir.
Namita? Okay. So if you look at the idea of universal health coverage, and there is a so in the around the world in the late 1970s, early 80s, across developing countries across the world declared that we should have health for all by 2000, and uh, we realized by the time 2000, the new millennium came in, that we are very far away from realizing that goal. And there, by the early 2000s and mid 2000s, the idea of universal health coverage came into prominence. And for the first time, we see at a global level the idea of coverage getting prominence. And from health for all, where healthcare was the prime concern, we went into coverage. And the term coverage here means essentially focusing on financing of healthcare, and so the idea was to secure sustainable financing for health systems so that some of the critical goals of health system can be ensured. And it is important to get a bit of the context, because this was also the time, 1990s and early 2000s, when the time of health sector reforms across the world, where public spending on health was cut back considerably, finances were curtailed, and we saw in developing countries a huge dependence on out-of-pocket expenditure. So the predominance of out-of-pocket expenditure and the UHC become a way to respond to this and reduce the burden of out-of-pocket expenditure. So the sustainability of financing in a way which is progressive became crucial. Next slide, please. So these next slide, please, Namata. There are this famous UHC cube that we have seen, and some of you would be exposed. But the idea was that there are few principles of financing that I'm sure Shankar has already spoken about. Is that we reduce the overall burden of out-of-pocket expenditure, and realizing that out-of-pocket or direct payment for healthcare is regressive. It creates inequalities across sections of people. It puts a lot of burden on households. So you try to create mechanisms where health, people are pulled together into some kind of mechanism of financial protection. Some call this pooling as a health insurance function. But we have to also keep in mind that when we talk about the term insurance in the theoretical sense, insurance essentially a pooling function where you bring people of various risks together into one uh, kind of system of coverage. It can be that a tax-funded, publicly provided system is also based on the principles of risk pooling. So often in the international discourse or nationally also, we tend to confuse the terms of risk pooling and insurance with insurance schemes. So that this is the key point that we need to keep in mind. And we also would see in some time that various countries across the world actually adopted multiple methods, including expansion of public spending for public provision. We are going to see that in some. Okay. So this essentially then this you can skip and you can go to the next slide, Namita. The idea is that you try to expand the unfair out-of-pocket based financing system to one which is more fair in the sense fairness means where people have greater ability to pay should be paying more, whereas people who need more services should get more service. Namrata, next slide, please. Uh, and also, the overall resources, more resources are mobilized for health. That becomes a key concern that you have more resources, which is called goodness of the financing system, and also the fairness of the system, which comes from uh, creating a system where people pay when they have more means to pay rather than based on their needs to pay for care. So we can go to the next. This I have discussed already. Next slide. And so in this effort towards moving to a system which is more fair and which also have goodness, you need to really eh, do three things. And these are the three dimensions of the famous UHC cube. Namita, we can go to the cube. Next slide. Yes. This everyone must have seen. So basically, the idea is that the people who are currently covered under some kind of financial protection mechanism or mechanism of risk pooling, you should expand the base. So if a small section of the population are covered, you should try to cover as many people as possible. And then the next dimension of UHC becomes that you try to deepen the coverage in the sense you bring in more services into the scheme of financial coverage. For instance, in many countries like India, you will see that basic maternal and child health services would be free at the point of care for public system for a large section of the population. But while you make it available for other non-poor, you need to also expand the basket of service coverage from, say, narrowly defined maternal and child health services to, for instance, care for non-communicable diseases, care for diseases which are causing very high levels of burden, for instance, care for cancer and all of this. So, this blue part becomes the part which is the covered or the scheme under a form of pooled resources. And the idea is if the transparent cube is the whole amount of resources required in health sector, you try to expand the blue part so that the height and the depth of the coverage increases and very little is very little here depends on households' ability to pay. So the transparent part is essentially the out-of-pocket expenditure, whereas the blue part is the pooled covered care part. And the idea of universal health coverage is that at the point of service delivery, you should create mechanisms where services are provided free, whereas if you need resources, you generate resources from uh, people based on their ability to pay. Next slide, please. Thank you. But this was the WHO cube that I showed earlier. But in reality, what we see in many countries, if we dissect the cube, you will see that rather than having a monolithic cube, we see basically a structure like a step pyramid where probably the richest sections of the society have the highest coverage. For instance, in India, we have the the defense personnel's health service. We have the central government health schemes, which are for civil servants or the defense. And in reality, we'll see that these schemes are most comprehensive. It covers all kinds of services. It covers for all out-of-pocket expenditures, and very little might be needed to pay from the pocket. So for the most for the people who can afford healthcare most, we have a system which is more comprehensive, which covers a lot of healthcare needs. Say, if you look at slightly lower down the order and say the white collar or sorry, blue collar workers in the formal sector, you will see that schemes like employee state insurance schemes which work, and they might be able to cover some decent amount kind of care for leaving out a lot of primary care needs or maybe very high end tertiary care needs, but they also constitute a small section of the society. And for large majority of the people, we see that the major source of service provisioning becomes either underfunded, and as a result poor quality public system, or other financial mechanisms. And the third option is to go and seek care in the market, which has huge financial consequences. So essentially, rather than having one holistic cube, we see a situation like a step pyramid. Now, the question is, how do we change the situation? And there has been several global experiments to make some amends here. Let's go to the next slide, please. If we look at around the world, there have been few most prominent mechanisms to uh, provide healthcare for all or provide uh, relatively better financial protection and coverage. There are countries like the NHS in UK or few Scandinavian countries where the major predominant form of financing has been where tax and public resources are collected, general government revenues are collected, and those resources are used to provide care directly, either through public system or like the general practitioners in UK, contracted in private providers for primary care, but essentially through a very highly regulated or predominantly directly provided public service. And like I said earlier, that those kinds of schemes, by definition, have the whole country or its citizens under the coverage in one financial pool. So it's a progressive kind of such system, because if you depend on tax resources and particularly direct tax resources, you end up the people who have higher ability to pay end up paying more money for healthcare, not at the time of provisioning, but beforehand. So paying what we call prepayment mechanism, not at the time of service delivery, but you pay beforehand. So we pay taxes beforehand, and tax money goes into provisioning of care directly. That's one model that many countries across the world have taken up. Other prominent model has been a model of which is where workers and their employers contribute for a health fund, and then the government also pitches in for certain kinds of care. These are called social health insurance. Here, the central theme is it's a mandatory deduction. Say 2% of your salary would go into your social health insurance fund. And then your employer has to also say contribute another 2, 3, XYZ percentage, and then government also pitches in. So it's a mandatory deduction from your salary, which contributes a large part of the financial resources. But then these kind of mechanisms, like India's employee state insurance schemes, essentially depend on the extent to which the formal sector is present in an economy. In a country like India, where large number of people are essentially in the informal work sphere without much contract, without a fixed employer, implementation of such scheme becomes very, very difficult. So in some of the developing countries, particularly taking examples from the United States Medicare and Medicaid program, there have been efforts to use tax resources or government resources and insurance schemes, so called, to bridge some of the characters of the social health insurance, but essentially also government funded program. And in India, we have the schemes like Prime Minister's Jan Arogya Yojana, which is modeled largely based on the Medicare and Medicaid in US, and with some appropriate modifications for the local context, where tax money is used and insurance-based schemes or other assurance kind of schemes can be incorporated into the same one. So these have been the large progressive kinds of financing systems across the world. Let's go to the next slide. So if you quickly look at the global picture, you will see that there are around 100 countries have some kind of predominantly general government revenue finance system. And 60 odd countries, mostly the developed countries, have social health insurance based models. But if you look at most of the developing countries, they have a mixed model where for some formal sector worker, there are these social health insurance. For informal sector, there are these government funded general revenue provision services, but also a large part of their healthcare needs are made by out-of-pocket expenditure. And UHC efforts were to reduce this extent of out-of-pocket expenditure. Next slide, Mamta. So now, so essentially, one of the main tenets of UHC became that you need more resources for health. The goodness question that I mentioned. Without having adequate resources, you may not be able to provide good healthcare for it. Like say the financing and health outcomes. If you look at the relationship, looks like rain and cloud, where financing is like a cloud which is essential for you to have rain. But then, if you look at data of some of the richest countries of the world, or say some countries where life expectancy or health outcomes are good, you will see that there is hardly any relationship between how much money is being spent on health to health outcomes. Let's look at this graph very carefully. These are countries with highest, or say some 20 odd countries with the highest level of life expectancy at birth. And if you look at, these are the red bars, and the country with the highest life expectancy, Japan, is on the left, and then we gradually move to a lower life expectancy. But you will see that the blue line, which is the per capita spending on health, varies very widely. Country like Japan has very high life expectancy, but public spending could be much lower. Look at the right side and look at the last two countries on this. By the way, these are the top countries with top life expectancy. If you compare US and Cuba, you will see that Cuba spends only a fraction, 1/10 of what US does, but they have very similar life expectancy. So that relationship between money and health often gets skewed. Let's go to the next slide. Here, I'm not sure if those who are watching in mobile, you will be able to read this slide, but if you zoom it, you'll see that I'm trying to show three kinds of relationships. While we said that the relationship between money spent on health and health outcomes are varied, we also very clearly see that if you look at, say, out-of-pocket expenditure and public spending on health, is more public resources spent on health? Does it have any implication on reducing out-of-pocket expenditure? The answer, if we look at countries across the world, is clearly yes. The each dot here is a country, and India is on the left top side of the dot of the graph, representing lowest levels of public spending on health and very high out-of-pocket expenditure. And the black line shows the negative trend. And if you look at the R square, which shows the strength of the relationship, you will see that very strong relationship between public spending. So if you increase public spending, your out-of-pocket reduces. Now, if you look at compare public spending with say other UHC, say overall UHC coverage index, WHO constructs this universal health coverage index, and if you look at public spending as a percentage of GDP and try to link it with uh, the UHC coverage, you will see that actually there is a very strong positive relationship on the lower part of this, that countries with much higher countries with higher public spending would have greater UHC coverage. Hmm. And countries which, but then that relationship, as we move along, that relationship weakens over high levels of public spending. So similar situation we saw earlier also when we saw aggregate expenditure totals. Now, the other point is countries who are generally richer, which is the bottom right panel, you see that richer countries have better coverage. So what are we essentially saying? That is it only the rich who can get UHC, or there could be other interpretations. So if we try to summarize these three graphs, what I'm essentially trying to draw upon is that increasing public spending is essential for universal health coverage and related outcomes, financial protection, but also we need to understand the resource mobilization potential of a state country. And it could be the case that many countries who are relative poorest of the parts of the world will have very little financial strength of themselves to fund their efforts towards universal health coverage. I'll just give you a comparison. For instance, the low income countries, and if you look at the per capita spending, public spending on health of low income countries are actually 100 of the level of per capita, average level of per capita public spending on health by the high income countries. So there is a huge gap between the level of public spending by countries. And there, I think the dependence on global mechanisms to redistribute resources for healthcare could be crucial. Can we go to the next slide? So, yeah. If we come back to Indian context, our low middle income country context, and try to compare India with some similar countries who are doing globally better around the world, and countries who are in our neighborhood, and some other countries we aspire to be similar with, for instance, the BRICS countries, you will see that in the blue part of these graphs, if $100 or rupees is spent on health, what are the contributions? The blue is government resources, and the red is out-of-pocket expenditure. The yellow is voluntary health insurance, and the dark one is the social health insurance. You'll see that there are various models. Some countries are like Cuba, essentially depends on public spending. Red is zero, no out-of-pocket spending, which is exceptional and of different context. But in our context, if you see countries like India, Pakistan, Bangladesh, we are on the other extreme where out of pocket is the most dominant form of financing. Hmm. And then there are only few countries who have social health insurance. And then another few countries like South Africa and to some extent Brazil depend on private voluntary health insurance, though these are also sometimes supported and subsidized by the government. So wide variation, but India remains at the one extreme where out-of-pocket dominance is the most crucial question. Next slide, Namrata. Okay. I'll not elaborate on this too much, but I think I'm also running a bit short of time. But to draw home the point that public spending on health in India, if we compare countries in neighborhood and also in, say, some countries like Thailand, Malaysia, Sri Lanka, who are relatively better placed in terms of universal coverage, they are spending a lot more compared to India. All the BRICS countries, if you look at, spend at least 5 to 10 times compared to India in terms of per capita spending or public spending as a percentage of health. Let's go to the next slide. But more importantly, and this is where I would like you to draw your attention to first, say the top left graph. You will see if you compare some with most countries around the world. I've randomly picked three other countries, but if you look at most countries of the world, current expenditure on health as a percentage of GDP, which includes, say, both out of pocket, but essentially public spending for most countries, is increasing. And India remains one of the exceptional country where total health expenditure is declining as a percentage of GDP. So our share of health in the total economy is shrinking. And then if we within that, if we look at, say, out-of-pocket expenditure as a share of GDP, of course, like I said earlier, it's one on the very high end, but then it is declining. And we tend to see this decline of out-of-pocket as a share of total health or say current health expenditure, which excludes the capital expenditure, the decline in this as a positive sign. But we need to look at this number more critically, and that's what I'm going to do in some time soon. Look at the graph on the right side. So these are some countries very randomly chosen, very different contexts, but public spending on health as a percentage of GDP, particularly current health expenditure as a percentage of GDP in India actually is remaining stagnant, almost stagnant. Though in nominal terms, there is some growth in public spending, no doubt. But then the growth, our level is much lower compared to many other countries. Similarly, the trend is also stagnant, where in other countries, out-of-pocket public spending is increasing. So what am I saying here? Just to summarize this argument, that in most countries, more resources are going for health. And these resources are essentially coming from public spending, so expansion of public spending. And if out-of-pocket is declining, that decline is not able to compensate the overall increase in health expenditure. So public spending is increasing much faster, and out-of-pocket expenditure decline is happening at a slower rate. As a result, the total health expenditure is increasing. So the size of the health economy is increasing in the overall economy. And that's the case across developed and developing world. In India, in comparison, what we see is a very particular situation where the health economy as it is shrinking, and public spending also in this old economy, particularly current public spending, is not increasing. It's increasing at a very low rate and it has just barely crossed 1% of GDP. Whereas out-of-pocket expenditure is declining. That's a relatively rare phenomenon, and we need to find some answers to this. And I'm going to throw some light on this in some of the future slides. Chandrakant, whenever I need to stop, please let me know. I think I have already spent. We started late, but at least 35 minutes I've spent on this. So I'll try to wrap up in another 10 minutes if that is okay. Next slide, please. So, if we this we can skip, but the basic, okay, sorry, 1 minute. I think when I said public spending is relatively stagnant, we also need to highlight this, that the spending by the union government as a percentage of GDP has remained relatively stagnant, whereas the spending by state governments have increased to some extent. So there is some increase in spending on health by the states. That's a positive development, whereas union government expenditure has not increased adequately, or rather, it had a decline in earlier phase and some recovery in the post-COVID period. Yeah. Can we go to the next slide? Okay. So remember, we had seen this earlier trend where at the global level that if a country is spending more on health, public spending is more, out-of-pocket declines. We also see similar trends in India. States in India who spend more on health also tend to have low out-of-pocket expenditure. There are a few exceptions like Kerala, where the overall health consumption is much higher, and both out-of-pocket and public spending are on the higher side. Kerala has a very high level of out-of-pocket expenditure, whereas public spending is also very high. I just wanted to show the national picture. So we have stagnant out-of-pocket public spending. Our out-of-pocket is declining, but in public spending, we see a lot of efforts from the state side, whereas union out-of-pocket public spending is not increasing. But also there is a lot of variation across states in terms of public spending, which has a negative consequence on the out-of-pocket. So states which are doing better in public spending are able to also curb their share of out-of-pocket expenditure. Next slide, please. Now, in this context, India has, this is a chronology of history of social health protection in India. We don't have much time to go into it, but I would like to highlight the later phase, and some of it is known to you, that since the 2008, we saw that in India also, it started in 2003 onwards, where government started providing insurance to some sections of the population. It started with Aragyasri scheme in Karnataka, where farmers cooperatives were trying to buy some insurance, and then government pitched in. And in 2008, 2007, we saw Andhra Pradesh introducing a scheme where they used tax resources, but also procured insurance schemes for a large section of the population to cover almost 85% of the people for hospitalization care. And then, of course, they made modifications. They did away with insurance schemes and got their own system of assurance in the model. But then this Andhra experiment became nationally very popular. We had in 2008 Rashtriya Swasthya Bima Yojana coming in at the national level. It was a modest beginning with 30,000 coverage for secondary hospitalization, but then that also caught attention of many states. And by the time, in a 10-year period from 2008 to 2018, we saw that there are more than 20 schemes introduced by states and union government together. For some states actually topped up the Rashtriya Swasthya Bima Yojana for including tertiary care. Some states expanded the coverage for beyond the poor section to include non-poor, like the Kerala experiment. And then in 2018, we get the Prime Minister's Jan Arogya Yojana. Though it drew from existing schemes, some of it, but then it had a new set of information technology platform. By the time IT has developed a lot, we see that now the coverage is 5 lakh, and also it became politically an important scheme. Now, the essential features remain very similar. It's essentially secondary, high-end secondary and tertiary care hospitalization for people in and around poverty, but largely bottom 40% of the population. And idea was that if care would be purchased from both public and private sector alike, though predominantly private, but people at the point of service delivery would get free care, even with the private sector. It looked a very radical idea that you can go with a scheme and walk into a public hospital, a private hospital, and get free care. It caught a lot of attention of people. But how effective these schemes were, and what were the trends of out-of-pocket expenditure? Did it reduce out-of-pocket expenditure? Were people getting free care when they went to private sector? Some of these data, what I'm going to show now, is before PMJ was introduced, because that is the last round of out-of-pocket expenditure household survey. We have 2017-18 round. So this analysis is not very valid for the latest scheme of Prime Minister Jan Arogya Yojana, and we are waiting for the new round of out-of-pocket expenditure from NSSO. But I want to spend another few minutes explaining whether the decline in out-of-pocket expenditure that we see, we saw earlier, can we attribute the decline to the expansion of the insurance schemes or not? That's one of the key questions. And the next question is that whether the when people had out-of-pocket, say, when people had the health insurance cards, the PMJ or RSBY card, and they went to private sector, did they get free care or not? Next slide, Namrata. Next slide, please. Now, what I'm going to argue here, there are a lot of numbers, but what I'm trying to show here is that between two rounds of NSSO, 2014 round and the latest 2017-18 round, we see that people reporting ailment in the country have declined. Out-of-pocket, hospitalization rate. Both of these are some kind of indicators of access, we can say. So hospitalization rate is very relevant here, because all these schemes are geared towards improving access to hospitalization care. So ideally, between 2014 to 2017-18, hospitalization rates should have increased, because if we compare earlier rounds, we saw every round from the early mid-1990s, hospitalization rate increased. When people have more purchasing power, there is growth in the economy, more ability to pay, and public services are also provided, we tend to utilize healthcare more. That's the global trend. But suddenly, we see in 2017 data that the trend reverses. This is from a paper we did jointly with Chandrakant and one of my colleagues, Montu, earlier, some of it, and then we expanded this. So next slide, please. So the decline in out-of-pocket expenditure could be a result of the decline in the hospitalization and people reporting ailment. Now, let us look at, try to compare NSS with some other data sources and see whether hospitalization rate could have been an under. The left side table shows a comparison with another survey, which is called longitudinal aging survey, which is focused on elderly population and their hospitalization rate for various diseases. And we compared the same set of elderly population uh, for NSSO to see what is the difference in hospitalization rate. We see that the LASI reports much higher rates of hospitalization for very many diseases. For instance, diabetes, a hospitalization rate in LASI is 5.46, whereas per thousand population, whereas in NSSO it is only 1.8. Huge difference. Similarly, for hypertension, huge difference in hospitalization. Stroke, twice in LASI. So my point here, we are arguing here that actually the hospitalization rate might have not actually declined, but could be much higher. On the right side, what we are doing is we bring in another data, the consumer expenditure CMIE data, to see what is the trend in out-of-pocket expenditure in this period. Has out-of-pocket expenditure really declined between 2014 to 2017-18 if we use the CMIE data, and then we compare that with NSSO? We see that in NSSO, the out of the bars are NSSO rural urban, there is a decline in real out-of-pocket expenditure between 2014 and 2017. So essentially, we are saying that per capita out-of-pocket expenditure in real terms, when we take out the effect of prices, have declined in NSSO. But then if we compare the CMI data, it shows huge increase in this period. So there is this discrepancy between NSSO and the CMI data, where so the decline in out-of-pocket that NSSO is presenting may not be the best estimate of out-of-pocket expense. That's the point that we wanted to make, and we need refinement of those estimates. Other point that has been already explained earlier, that access to healthcare has also reduced in this period. Next slide. So it has to be also kept in mind that this was the time in India, for international audience, this was the time when demonetization happened. And this was the time where particularly rural households and households in the informal sector faced a lot of financial crisis just before the NSSO data came in. And for various age groups, we see that age and social groups, not age, sorry, social groups, that hospitalization rate has actually declined. So, and these financial protection schemes like RSPY have not been able to protect people from hospitalization decline. So that's a cause of significant worry rather than celebration of out-of-pocket expenditure. So next slide. I'll skip this. I'll skip this one. Yeah, go ahead. Next slide, please. Wait, please. While I said that overall out-of-pocket is declining, hospitalization rate is declining, and also said that people have less purchasing power now, we realize that if a person goes to hospital, per episode, cost of hospitalization from out-of-pocket has increased significantly in this period, both rural and urban. The irony is, say, earlier, if you do not have any health insurance card and you go to a public hospital, you end up paying, say, on an average, say 4,000 or 4,500 or so in a public hospital. 5,000, around 5,000 in urban area. But if you have an insurance card and you end up going to a private hospital, you end up paying on an average 20,000 Indian rupees. So 4 times more. So these schemes, while brought a lot of people to private sector, per episode, out-of-pocket expenditure increased considerably. This is a crucial finding. So healthcare is becoming more expensive even if you have the cards. But then, what is the state of free care? Are people receiving free care if they have card? Next slide, please. You'll see that I mentioned earlier that these schemes, the RSBY and PMJ's predecessors, covered both hospitalization in both private and public sector. Whatever free care was provided came only from when people went with the car to public hospitals rather than private sector. So if you had a card and you went to public hospitals, two-thirds of them ended up paying less than, say, 2,000 per hospitalization episode. And some percentage got the care free. In fact, 30% paid less than 500 rupees in India. If you, for global comparison, 500 rupees means actually $10 per hospitalization episode if you take care of the purchasing power parity. If you go with the card to a private hospital, more than two-thirds ended up paying 5,000 rupees or more. And a lot of them paid more than 10,000. So much more out-of-pocket expenditure and very little free care. Let's move ahead. Next slide, Namrata. So and this is going to be one of my last data point, and then I'll give you some um, suggestions for universal health coverage for India. The last point is a lot of the care that has been provided could be seen as induced care. For instance, ideally, cesarean section rate for delivery should be around, say, 10 to 15%. Now, if you have an insurance card and if you went to a private hospital, this is NFHS data, the cesarean section rate becomes much higher, and it's around, look at the rightmost bar. Private sector government funded health insurance schemes have cesarean section of rate of 55%. So more than half of the deliveries are happening through cesarean section in the private sector if you have the insurance card. So much when you so definitely some bit of cesarean section improves maternal health outcomes, reduces the risk of deaths to a great extent, but some of these could be attributed to induced demand. So we need to really look at these numbers more critically. Now, so essentially what I'm arguing here is that a lot of care could be unnecessarily provided through some of these insurance schemes. Now, what is the way ahead? If the insurance schemes are not able to improve access to care, it's not able to reduce out-of-pocket expenditure, and a lot of care could be unnecessary. What do you do? How do we change the situation? Uh, uh, Last slide. And I would prefer to keep this hanging here because each of these needs a lot of explanation. I would like people to read it, but very quickly, my closing observation would be we need more public resources. We need public spending to increase to 3 to 5% of GDP. When I say 5%, it includes other social determinants, immediate social determinants like water supply, sanitation, nutrition, but also we need a lot of the expansion of preventive primary care, outpatient care services, which can prevent high-end hospitalization expenditure and regulate the overall healthcare cost. There have been efforts in many countries around and within the country also, where strengthening public system and primary care has been the fulcrum of universal health coverage, whereas in countries like us, we are depending more on tertiary high-end coverage to reduce out-of-pocket burden. This may not be the most cost-effective way of doing this. Chandrakant, I'll stop here. I took a lot of time and probably I overshoot my time significantly. I request you to take forward from here. There are some questions.
So, Chandrakant sir, you are not audible. Sir, you are not audible. No, sir, you are not audible. Okay, so I thank you so much, sir. Thank you so much. Your insight really helped us in understanding the topic discussed. Now we are heading towards the question and answer session since we know this is the interaction between the fellows and our speaker. So I request our speaker to ask question. We already have two question in our comment box. So, am I supposed to deliver, or Dr. Rupa Shri wants to ask question by herself? Should I ask on behalf of her?
Thank you so much for the opportunity. I really would like to thank the speaker and also Dr. Chandrakant sir for organizing such a wonderful topics and also the Foundation of People. Yes, I have two questions to ask you, sir, pertain to Indian perspective. May I please ask this question? My first question is, as India has highest number of population in numbers, the public spending on healthcare has to be proportionate to the population number. So what is the need-based analysis? How do we go about and determining the resources allocation? This is my first question. My second question is pertain to the, as a policy matter from public health perspective person, how do we strategize or plan of action for the future for the betterment of quality of care in Indian perspective? Do we allocated resources as need based, or is it population based, or is it GDP based, and how do we break it down? That is my question. Thank you so much.
Shall I respond and then we can take more questions? There is one more question very quickly. So, of course, we see these are indicators: per capita expenditure, health expenditure as a percentage of GDP. Each indicator depicts something, it hides something. So, whatever you take, basic point is our public spending is much lower compared to any other country. So that argument that our GDP is growing really fast, we cannot spend. If we look at per capita numbers, for instance, say, let's take G20 because we are in the middle of G20 in India. Compare other G20 countries. The lowest public spending in G20 is, of course, India. But what is the extent of variation? Indonesia, which is the next low public spending, spends 3 times per capita. Most other G20 countries spend 10 times. Mexico is the third lowest, and it spends 10 times compared to India. And rest spend many, many, many times. So whatever we say, percentage of GDP or per capita, we need more public spending. But having said that, can we afford to spend 5, 7, 8% of GDP on healthcare? As a country which has limited resources, we cannot probably afford that. So what do? We should, and that's where your strategy question comes in. So we should strategize in a way that we reduce the healthcare cost inflation. In many developed countries, healthcare cost is shooting like in a very fast pace. So the way to curb healthcare costs and expand healthcare in a most effective way is to focus on preventive and primary care. And also within the secondary care, you introduce principles of generic medicine, provision of diagnostic care. See, unless you are able to curb unnecessary healthcare, like for instance, what I depicted for cesarean section. If say ideally maybe in a poor health setting, we need probably 25% cesarean section on a very optimistic scale. But then it cannot be 50%. It means that half of the cesarean you are doing are unnecessary. It's a waste of resources, increases the cost of care. So we need to create incentives within the system which reduces these unnecessary care. Lot of branded prescription. This is the current debate we are having. We do not have probably the supporting structure to provide generic medicine. But then one source of out-of-pocket and high cost remains the branded medicine sector. How we can rationalize it? And some states have excellent models of procurement, centralized procurement and decentralized distribution, which can be used. So various strategies, but essentially you need to reduce the extent of commercialized healthcare to the extent possible, so that you have rational care, you have care at an affordable rate. That would be my limited submission. There is one about insurance scheme. Shall we read out, or
Thank
I
you,
would
sir. Thank you so
prefer?
much.
Yeah, there is a question from Mansi Tongwar. Shall we take Mansi's question? Mansi, would you like to?
Yeah,
Namrata,
yeah, sir. Sir, actually, private insurances only covers hospitalization. They don't cover running OPDs and all. So, after paying such high premiums, still we are paying so high for OPDs and all. So that is also increasing our out-of-pocket expenditure.
So definitely, see, if you look at out-of-pocket expenditure burden, more than half is on outpatient care. 40% is hospitalization. And within that outpatient care, more than two-thirds is on account of medicines. And some on the diagnostics, around 10%. So your almost three-quarters is medicine diagnostics of the out-of-pocket expense, outpatient out-of-pocket. So you need to really come. Now, why insurance schemes do not provide inpatient care, outpatient coverage beyond the limited hospitalization, post-hospitalization care and pre-hospitalization? Is because insurance mechanisms, insurance schemes will not be able to uh, control costs for outpatient care. For such care, you need more coordinated, publicly provided models where rational care can be provided. So insurance mechanisms have never worked without huge burden to, even if you look at, say, Medicare, Medicaid program, a large part of US, a large part of the out-of-pocket expenditure is on medicines, on prescription drugs, and branded medicine. So we need to really work on these rather than focusing too much on insurance.
Thank you, sir.
Okay, so
Namrata, any other question? Yeah.
so in comment there is no questions, but yeah, please
There's a
ask.
hand by
You can unmute
Anthony.
yourself.
Yeah, good evening, everyone. Good evening, sir. That was a really
Fine.
wonderful. Am I audible, please?
Yes, we can hear you.
Please.
Okay, thank you. So my take on your presentation is don't you think that we are thinking always in terms of public as a whole rather than thinking on individual as an entity? The whole policy design, it's more like we are thinking about what people who are at the lowest strata want. Though we know that whenever we try to reach out services from the government side, it's always directed towards the people who are at the last mile. But when people want to have their choices, it's always like they want to have the products which are at the best level. And somewhere down the line, the policymakers are ignoring this fact. This is my take on the whole discussion. Like this example, like generic versus branded, we all know that till date, there is no mechanism which will ensure that the generic medicine is as efficacious as a branded one. And even in the branded one sector, we all know that there are many counterfeit medicines which are available. Till that, we are not having any system which can ensure that what I'm getting from a drug store is not a counterfeit one. Still, we are not talking about those terms, but what we are thinking that generic medicine should be given to everyone. Why? Because someone sitting at the policy level thought that generic medicine is cheaper. The problem is when that person who is at the lowest strata of the society, who will be handed over by the doctor the generic medicine, will be taking that, and because the generic medicine is not tested, the quality is not ensured, the medicine won't work. What will happen? The individual who has been prescribed a generic medicine which is below par quality will come back to the doctor. He will say that you have not treated me well. What will happen? There will be anything like patient is losing his time, his money. Doctor is also losing his time, money, effort, dignity also. So where it is going? See, I might be getting off the whole thing, but this might take that. Shall we consider these things when we are sitting at the policy level also? This might take. Sorry if it is way off of your presentation.
So, no, it's very central and a very good question, Rishabh. Thank you so much. Let me also say that when you said we generally invoke people's choices and poor people to say which is commercially more fit. Is there any way to, is this notion about linking generic to poor quality, like you also, if I draw from your own statement, is there any way to say that the branded medicines are better quality? So there is actually no connection between brand and quality.
No, this counters because when we go and purchase something and when we know that we are having the genuine thing, high brand, so generally the quality that it will be good. Like for instance, you purchase an app. No, it is not a misconception. It is the thing market is working. Everyone, like, why you are using an Apple iPhone? We all know that the phone is going to give you the basic things, but we all know that when you are using Apple, it will run more smoothly than any other phone, any other Android you pick. Apple is always going to run smoothly. That's why everyone is buying Apple. There is no other reason for one to buy Apple. And this is the system, how market is exploiting and how things are working everywhere. You go anywhere, you take any instance, you wear a shirt which is branded, most probably it is Van Heusen or Arrow or whatever it is. Why you purchase it? Because deep in your mind, you know that when I'm going to give this money and I'm buying a product from Van Heusen or Arrow, I will get a good product. It is not like that those products are bad. Getting a good product which will last. And that's how the market is working.
So, okay, Rishabh, now Indranil, you respond. Like Rishabh, you have made your point and it's very clear. So let Indranil respond. Yeah.
Oh yeah. So we are like
Rishabh, are you through? Shall I respond? Chandrakant, am I audible?
Yes. We had lost you for a while, but you can now you are audible.
Okay. Sorry, I think there was some disruption here. So the main difference between Apple and other phones and generic and branded medicines is that the fundamental difference is, say, if you take iPhone, and that same iPhone, if you sell as iPhone made from, say, X, or say packaged by X source, and iPhone packaged by Y source, and have huge price difference, would you still justify those price differences? iPhones and Android phones are fundamentally different products. Ideally, a generic medicine, the salt is supposed to be the same. Whatever cover you put doesn't make it a different product. So that analogy between iPhone and other phones and generic and branded medicine doesn't hold true. Because a paracetamol sold at 30 rupees for 20 tablets of 650 gram by Cipla is sent to a public system at 2 rupees per 20 tablet. It is supposed to be the same salt, the paracetamol. Now, the quality issue is a different issue. There is no study to also say that the generic medicines are of poor quality. Because the
Yes, there
end,
is one
the main. So let me.
we don't have that.
Rishabh, let Indraneel finish. Yeah.
So the point
Yes.
is, now there is some issue in healthcare. The issue of choice in healthcare is limited because there exists huge information asymmetry. What is information asymmetry? The knowledge about what we are consumed, we don't know. We don't care about what medicine we are taking. We care about improving our health. We don't know what medicine to take. We don't know which hospital to go to. So that's why the role of doctor becomes crucial, because doctor is my agent to provide the best healthcare that I need. So she works on my behalf to uh, navigate my choice of healthcare. So the question of choice really is a notion that market creates, but there is actually in reality there is very little choice that we can exercise. We don't have the information to know whether, say, paracetamol sold by Cipla is better or paracetamol sold by Ranbaxy. The doctor does that choice on our behalf. And if there are incentives which governs doctors' choices in a certain way, then the whole system gets geared towards more commercialization. So the product differentiation and choice question remains very contentious in the case of healthcare. Actually, it's more than choice, it's the trust that works. And we need to create systems which is based on trust and solidarity rather than choice. And if you really talk about people-centric health system, it's the people who people are not. This notion has been created deliberately that high cost things are better in healthcare. At least that doesn't hold true for medicines, if not at all in other products.
Thanks,
The analogy is
Indraneel.
very-
I think this is very exciting discussion, and Rishabh, this is the reason that we want to do another webinar. We are bringing all the experts and allowing the participants, panelists, and some of the YouTube viewers to reflect and think about these aspects. So I'm mindful of the time, and time is equally important for these things. So Sayantani raised hand before Rishabh started. So
Yes.
last question from Sayantani, and then we will close.
Sir, actually, I want to ask about the maternal health, because pregnancy is a condition. So there are many health insurance which is not covered the pregnancy condition. So, because of their another factor is willingness to pay. Because of that, the highly educated women wants to pay and went to private hospitalization, and that could be a very much important reason for out-of-pocket expenditure. So I want to know about this on your side.
Yeah. Thanks, Anthony. It's very important and complex question. For instance, if you look at the cesarean section rate among, say, urban, most educated, say, top, higher educated section in urban areas, some of the states like Telangana, Tripura, West Bengal have 90% cesarean section rates. Those who can afford are getting care. One may say, what is your problem? They can afford, and this is an important life event for people. So they are paying for it and getting the care. And also the care is of better quality because there is lower risk of any maternal death or anything, right? Now, how do we, as public policy practitioners, how do we see this problem? See, if there is a market which is higher paying, it's not only about I or my affordability. It also creates incentives for practitioners to cater to that market. So you see that there are districts in Madhya Pradesh, Chhattisgarh, in Jharkhand, in Bihar, there is not even a single gynecologist present, or obstetrician present. In Orissa, many of the tribal districts will have only one or two gynecologists. And see the density of gynecologists in Chandigarh, in Delhi, in Kolkata, in Bangalore. So you are creating a distorted system and you're creating a system which is geared towards those who have the ability to pay. It's not that they're getting better care is the problem. That's fine. So long you are also able to provide basic necessities for the so the whole thing about specialized, say in medical professional, the earlier say the client, say cloud the general practitioners used to have, or say the family physicians used to have, that's waning away because there is a incentive for specialized care. The market is pushing the doctors to MBBS degree is not enough anymore. So you need an MD to do that. So you create a disbalance between the need and the demand. So it distorts market, and we call this phenomenon as a welfare loss to the society. You are providing unnecessary care to a section of the people who can afford, whereas those who need care are not getting the basic care that they need. So at a macro level, as public policy, it is good to see as a whole rather than trying to promote market saying that it is about people's choice. That we need to reconcile between the.
Thank you very much, Indranil. I think it was really fascinating discussion. Thank you very much for covering a new dimensions. And I must congratulate you that though this is your third talk in the series, but you have brought a completely new dimension. And that is the power of bringing good expert, a subject expert, that you have brought in new dimensions. I also want to say that you have completed the whole picture. Like that's the way we have envisaged as part of this PHC, part of this FPHS Health Financing Dialogue 2023. So I should stop by saying thank you very much, Indranil, for this wonderful talk, and thank you very much for participants. Over to you, Namrata.
Thank you, sir. I was about to speak. Okay. Thank you very much, sir, for your time. And I also want to thank our participant because they have asked such an interesting question and they have contributed so much that this webinar is very, very interactive now. So I want to request all of our participants to turn on their camera so that we can take a snapshot. Yeah.
Meanwhile, can I say also thank you to all of you for your questions, to Namrata, to Chandrakant for this opportunity, and also brilliant set of questions. I hope there will be some debates that I have been able to invoke in your mind and thoughts, and that's the whole purpose of some of these conversations. And if I have left some unanswered questions, I think that's where that's what is the whole purpose, that you get to ask yourself and others some more questions. Thank you so much.
Thank you so much, sir. So, okay.
A few more people to switch on their camera.
Yeah. Mr. Satish Kumar, Mahima Mishra, if you can. So I think we will take the snapshot of this. Okay. Okay, sir. Done, sir. Thank you, sir. Thank you, everyone.
Thanks. Thank you. May I leave the call?
Yes, sir. You may, sir.
Yes, thank you. Thank you very much, everyone. Bye.